We are getting started with the 2021 HS Awareness Virtual Summit Day 2. Thank you so much for joining us. Yesterday was such a great conversation with Dr. Lynn, and we talked about genetics in HS. And it was a lot of potent information, but today we are going back to the basics. And we are learning about what is HS, how does it present, who does it affect, what is the definition, where does it present. All of that information is going to be given today because it's important for us to know, and not every patient knows. There's some patients who have had HS for more than 2 decades or even just for a year, and they still don't know what HS is. So if you're that person, there is no shame whatsoever. We are here for you, and we are here to give you all the information so that you can know exactly what you have and what you're dealing with, okay? So before we get started, I want to give an amazing shout out to the sponsors who have been able to make this happen. This summit is a labor of love from myself and my organization, My Gold Lining Incorporated, but we would not be able to do all of this without our sponsors. So I would love to give a big shout out to HS Connect, Hope for HS, also Designs by Muriel, and 100-page journals, the Mama IU, and then also Hydraware, the HS Foundation, and Sugar Lovin'. Thank you so much for donating your time, your talents, your resources to making this event happen, because this means the world to me. And I know that this is blessing so many HS patients' lives. So thank you so much. I am going to introduce Dr. Stephen Daveluy. Thank you so much for joining us for today's conversation on understanding HS. Please take it away.
Thank you, Jasmine. Thank you for the opportunity and the invitation. I'm so excited to be here, and I didn't even know there would be prizes. That is even better. I love prizes. So congrats to the winners. That is super awesome. As Jasmine mentioned, we're going to talk about sort of the basics of HS. So a little background on me. I am a dermatologist in Detroit. I work for Wayne State University, and we have a residency training program where I supervise the residents and teach them. And luckily, all of our residents graduate experts in HS, which we're trying to spread the gospel so that every residency training program in dermatology does that, and we will get there. So without further ado, I'm also on the board of the HS Foundation. So we're so happy to support this event and so happy to be sharing our information. I do some research in HS, and I'm looking to do more. And we're just looking to make life better for everyone affected by HS. So I put together a little PowerPoint, and we'll kind of run through that first, and then we'll get to the best part, is just question and answer, finding out what everybody's burning questions are. Hopefully I can answer them all. If not, I will commend you on an awesome question that I don't know the answer to. So like I said, I'll run through the slides a little bit. They've got a lot of the basic info, and then we will just open it up for discussion. Unfortunately, as a lot of people probably know, there's a lot we still don't know about HS, and we're kind of learning a lot and making new discoveries all the time. So it's an exciting time for people affected by HS, but it's a challenging time too. Ooh, let me get this click. Okay, so as a little background, just some basics. HS is estimated to affect about 1 to 4% of the population. It's more common in females. So for every 1 male with HS, there are about 3 females. It's also more common in African Americans, almost double the rate we see in Caucasians. And it's kind of interesting. We didn't know that at first because some of the early research was from Denmark, where they have majority Caucasians, so they couldn't actually do it. It wasn't until some work that was actually done here in Detroit that they discovered that it did have what we call a racial predilection, where it's more common in African Americans. Onset is usually a little bit after puberty, so your 20s, but it can present earlier. Especially, we see it more commonly for showing up early in people who have a family history. So people with HS who have kids, their kids are at risk of having HS earlier on. And then this is one of the things that we really are working to change, is that unfortunately, there is still, on average, a 7 to 10 year delay from when people first start noticing their HS and it first starts showing up to the time that they actually get a diagnosis of hidradenitis suppurativa. So we're working to combat that. And it's not like people are just staying at home and not going to the doctor, because in that delay, there's an average, the patients have seen an average of 5 doctors over 17 different visits for their HS. And those are the averages. So some people it's even more, some people, hopefully it's less as doctors are getting more aware of it. And a lot of this we see because the majority of patients don't present to a dermatologist. They present to their primary care, urgent care, an ER, sometimes gynecologists, some of the physicians who aren't quite as great at picking up the clues that this is HS and not something else. So we're working on that awareness in the physician community because we really got to get rid of that delay. We want to make the diagnosis early so we can get appropriate treatments and people can know what they have, because almost every HS patient I meet has gone through the struggle of not knowing what this is and no one giving them useful information. And they get to me and they're like, oh my gosh, I'm just so glad that you know something about what I have. Clinically, it usually, the lesions are like a skin spot. A spot on your skin is called a lesion. So the lesions we see in HS are nodules, which are those red swollen lumps underneath the skin. Abscesses, which are really similar to nodules, but they have the fluid, and the fluid is kind of close enough that you can sort of feel it. So those are those ones where you can tell it's going to burst soon, or it's at the risk of bursting and it's fluid filled. And then there's tunnels. And some of you may have heard us use the word sinus tract or fistula. And we're really moving toward just calling them tunnels, because sinus tracts and fistulas have sort of other definitions in medicine. And tunnels is more inclusive, because sinus tract or fistula, it depends what it connects to inside. So we've said, all right, let's just start calling them tunnels, because we don't always know what they connect to. And tunnels is a more accurate term for them. And then, of course, unfortunately, it causes a lot of scarring. So scars are another thing we see quite a bit in HS. They can be large. They can even cause contractures, which is where it contracts an area and pulls it together. And so you might not be able to raise your arm as much as you used to be able to. The common locations are the armpits, the groin, under the breasts, and the buttocks. But you can see it in a lot of different areas as well, especially in severe cases where it can start showing up in more areas. And then in terms of symptoms, pain is the #1 symptom of HS. And I already saw in the chat that some people are struggling with it today. And I feel for you. It is the #1 problem with HS, is it's just so painful. Drainage is a big problem. Sometimes the drainage can have odor. And then we actually see quite a bit of itch with HS too. And a lot of it we think is associated with the drainage causing some irritation. But itch is kind of the underestimated symptom of HS that we don't talk about as much. But when you start asking patients, a lot of them actually do get a lot of itch with their HS. And then one of the other keys with HS is that it's recurrent. So it comes and goes. It has flares and better days. And I think probably every patient who's on the call can relate to that, that there's good days, there's bad days, it flares up, it can kind of calm down for a while. And one of our patients who works with us in some of the activities we do calls it the roller coaster from hell, which I think is a pretty good description. And then the other term we use to describe it is chronic. So that means it's a long-term disease. It's not like the flu where you have it for a little while and you heal up and you don't get it again, or an infection where you kind of get over it, or a broken bone that heals. It goes on for a long time. It doesn't just come and go away. Then HS is plagued by a lot of myths. And a lot of these myths, unfortunately, hit patients with HS. So I'm sure some of the patients on the call have been through some of these where doctors or pharmacists or even other people who sort of know something about HS tell you something that just isn't true. So a lot of times it's called an infection, or people misdiagnose it as an infection or an STD because it presents in the groin, or even sometimes doctors don't know what it is. And so they start checking for STDs, which brings some stigma with it and makes you feel like, oh my gosh, now this doctor thinks I have an STD and he's passing judgment on me. It's also not caused by obesity or by smoking. So there is an association with obesity and smoking. And there's been some studies that showed weight loss and stopping smoking can sometimes help the HS, but it's not a cause and effect thing. It's not that you got HS because you're overweight or you got HS because you smoke. But there is an association, but some people mix that up. Even doctors kind of mix it up and go, oh, well, it's a problem of obesity. Also, totally not related to hygiene. As we'll talk about in a couple slides, it's more related to your sweat glands and hair follicles than anything else. But it doesn't mean that you're not doing a good job washing. The other myth that we hear a lot, and we're trying to dispel this, especially among doctors, is there are no treatments. They go, yeah, it's just one of those things, or the only treatment is surgery and you can only get it when you're really severe. That's kind of the old school way of thinking about HS, where there weren't super great treatments. And I'll be honest, there still aren't super great treatments, but we don't give up now. We keep trying things and combinations of things until we find something that gives some relief. So that's another big problem we have, is doctors who don't even bother referring patients or giving any treatment because they go, oh, nothing really works for it. Sorry about it. Just go home. So these are the big myths, and we're trying to really dispel these. Awareness is a big key part of it. We're trying to spread information among people and patients and the public. And we're also trying to educate our colleagues, physicians, physician assistants, nurse practitioners to be more aware of HS and stop making these mistakes. This is a little schematic. The top left part kind of talks about the HS lesions, and it's that sort of light orange color, and it shows where they are. Then the other things on the slide, especially at the left side and at the right side, are diseases and problems that are associated with HS. So sometimes what we'll do is we'll look at a group of people, and we'll look at a group that have people who have HS, sort of our HS patients. And then we'll also look at a group of people who don't have HS and see what other things sort of come with HS or are associated with it. So psychological issues are a big problem with HS, including anxiety, depression, a big impact on quality of life. That's what QOL means. It really affects your life having HS. It's not, some skin disease that you can just hide and ignore. It really stops you from doing the activities you like and causes pain. And then sexual dysfunction is a big part too, especially because of the areas that are affected. And then we talked a little bit about the metabolic issues that can come along with HS, but it can actually increase your risk of heart disease. And then a lot of people know that it can come along with joint disease too, including joint pain and even arthritis. It can come along with inflammatory bowel disease, and then hormone issues, which is endocrinology. So there's something called polycystic ovarian syndrome. So these things, it's kind of like I was saying earlier with the obesity and smoking. It's not necessarily cause and effect. You have HS and then you get arthritis, or you have arthritis and then you get HS. But the two happen more commonly in people than people who don't have one or the other. So it's an association with those diseases. And we don't know exactly why they happen and if one thing is causing the other, or if there's something happening in the body that's causing both of them, like just an inflammation problem. And then at the top right, it just lists off some of the things that we know are sort of pathogenic, which pathogenesis is like the cause of disease, the root cause. So what are some of the things that we think influence the disease or have some role in causing it? And so hormones are one, and that's why we think there's a female to male ratio of 3:1, is because there's some involvement with hormones. The microbiome, which is basically all the bacteria that live on us, we are just covered in bacteria, and most of the time, they get along with us and they don't cause problems, but they can cause problems. And we know that in HS, there's bacteria inside the lesions that we don't see in other places. And sometimes it is the normal bacteria, but just much more in numbers of them. And we think that maybe that might be triggering some of the immune reactions. So these are kind of active areas that we're looking into to figure out what are the root causes, what is not balanced in the body when HS is happening. As I mentioned, cigarettes have been shown to cause problems. There's actually a nicotine receptor on your skin cells that can trigger HS when you have nicotine in the body. Then, of course, stress, it just throws everything out of whack. And then genetics. You heard a lot last night if you were at the talk about the genetics of HS, and there's a lot of study going on about the genes. About 1 in 3 or even a little bit more people with HS have a family member who has HS. So this is a little bit about, we're really trying to dig down and be like, okay, what is causing this disease? What is the first thing we notice? So sometimes they'll do these studies where they look at the skin that's affected by the HS. They look at the skin that's right next to it. The area that doesn't look like it has HS, but it's in the zone of where they're getting their HS. So it's next to a lesion. And then they'll look at other areas of the skin and kind of compare them. And one of the things they found is This number one is follicular occlusion and dilation. So that means the hair follicles are getting plugged up and then they're sort of swelling up at the bottom, because usually our hair, the hair follicle makes some oil. So that's why when your hair comes out, it's not really dry. It's kind of more oily near the scalp, but when it gets longer, it's drier. And that's why your scalp can sometimes get oily. So it blocks up and that oil gets trapped in there. And there's actually bacteria always living in our hair follicles because they're usually open. But once it gets closed, then those bacteria are trapped in there. And then as the hair follicle gets bigger, it ruptures and breaks. And then the body says, hey, this stuff isn't supposed to be in here. It's supposed to be in the hair follicle. We've got to attack it with our immune system, get these bacteria, get this oil that's not supposed to be here, kind of destroy it, clean it up. But something goes wrong, and that inflammation leads to these tunnels and sinus tracts forming, and they have bacteria. They have a biofilm, which is like where bacteria kind of sets up shop and makes a little film. So we're learning more and more, but I just put this up here to kind of speak to the fact that we know there's certain things involved with HS. So one of them is the hair follicles. One is the oil glands. One is the immune system and the way it reacts to everything. And then another is the bacteria that are involved in there. And it's really hard to say, which one is the smoking gun, which one really is the root cause. It's probably a combination of things. And that's where some of the genetics might come into play, where maybe it has to do with your hair follicles and your immune system. But if you just had the hair follicle problem, maybe you wouldn't have HS. So we're digging deeper to find out more and more. And I'll say we're doing this with a lot of diseases. We're really trying to get to the root cause, and it's hard. We are very, very complicated organisms, human beings. Our immune system alone is so crazy. So it's a tough thing, but there are really, really smart people working on it, and we're learning more and more all the time. And luckily, these things lead to new treatments, new things to prevent disease, new ways of understanding the disease and how we can approach it. So we're still got a long way to go, but we are making some really good strides in understanding what is the cause. Then kind of taking a step in the other direction, we'll talk a little bit about treatments. So whenever I talk to my HS patients, I always kind of talk about there's two major divisions of treatment: the medical stuff, which is like medications, and then the surgical side, which there's actually kind of a range of surgeries, and we'll talk about them. I always talk about HS in the context of, as just a good way to understand how treatment goes, is sort of like a house fire. So at first, the house is on fire, and the fire is like the inflammation. So we use our medical treatments to put the fire out. So that's the fireman. So we need the fireman to come and put the fire out. But then the fire has left damage to the house. So HS damages the tissue. It causes scarring in those tunnels. And sometimes that damage can't be fixed by the firemen. Once they put the fire out, the damage is still there. So then you need your surgical treatment. So that's your carpenter who's going to come in, fix things afterward, fix things that the medicines can't heal but are still giving you problems. So a lot of times the fire is the inflammation. So the red nodules that are painful and swollen, the abscesses, that redness that you see in the skin that shows that it's inflamed. And then you can get that calmed down, but sometimes you still have one of those tunnels that just keeps draining. And no matter what kind of medicine you take for it, it doesn't seem to help. So that's when we say, all right, that spot's going to need some surgery. It's healed the wrong way. And that's the problem, is that it's just healed wrong, and it's not going to be able to get fixed with the medication. The other things to remember with HS is that there is no one size fits all treatment, unfortunately. It's a lot of kissing frogs to find princes. Luckily, the medical therapies are the firemen, so it's a lot of kissing firefighters till you find the right one. So that's a little bit better image than kissing frogs, but it's a struggle. So I always tell my patients, this is our journey that we're starting together. Unfortunately, it's not really easy to find the perfect treatment for you, but we are going to keep at it until we get some sort of balance and improvement and get something that can help improve your life. And then the other thing I remind people is that, like I just said, a lot of times we need combinations. If this treatment helps you 10% and this one helps you 15% and this one helps you 30%, when we add them all up and you can combine them, then you do get a significant improvement. And I bring it up for two reasons. One is I usually tell people, sometimes you can't really tell how much a treatment is working, and then you might stop it and you go, oh, that actually was kind of helpful. And that's one of the things that's hard both having HS and for someone assessing HS, like me, trying to figure out if the treatment is working, and even for studying it when it comes to like a clinical trial, is that the HS has good days and bad days. So depending what day you ask somebody, like I sometimes have a patient come in and I go, oh my gosh, I don't think that treatment's working at all. And they go, oh, no. I'm just having a flare. Today's a bad day, but this is the first flare I've had in 3 weeks. So I'm super happy. This is way better. Other times people come in and I go, oh my gosh, you look great. And they're like, yeah, but this is the first good day I've had in a month. This treatment is not really working, or maybe it's just now kicking in. So it's a really tough disease because it's hard to sort of figure out, all right, am I having less flares, or are there more time in between them? Are they not quite as bad? Versus, a treatment where you go, oh yeah, I haven't had a single flare. Like that would be just awesome. If it was like, oh yeah, you start this, you'll never have another flare. Unfortunately, we're not there yet, but we're working on it. Then this is kind of a summary of the treatments. I know it's kind of a busy slide. This is actually a picture from the HS North American Clinical Guidelines that came out in 2019. So this was a really big group effort by a lot of HS experts to look at the literature to see like, all right, what treatments have been tried, what ones have been proven, what ones work, what ones don't seem to work so well, and then to make some recommendations. And so on the left there, you can see it kind of breaks it down into the medical treatment, the procedural treatment, which is like the surgical treatment. Then the one at the bottom is acute lesions. So acute means like right now, it's just started, it's happening, it's flare. So it's like a flare. So these are some of the things you can do for flares, because sometimes that's like a different aspect of treatment is, all right, what can I do when someone's flaring up and it's really painful right now? And then at the top is the Hurley staging, which is sort of akin to mild, moderate, and severe. And a lot of you might have heard the Hurley staging. So Hurley stage 1 is where you have one or a few lesions. They're not really leaving much in the way of scars yet, and they're separated. Hurley stage 2, you start to get more scar and tunnel formation. So even when it's not flared up, you can still tell you have HS. And then Hurley stage 3 is where it's so severe, it basically takes over the whole area. So it takes over your whole left armpit. It's just taking it over with scars and lesions. And it's not a perfect system, but it is sort of a good way to say how severe is the disease in a certain area. And so as you can see, these lines just kind of show that we sort of look at treatments for different stages of the disease. Some things are good for early disease and aren't so great as you get more severe. They're not as helpful. Others are more helpful when it's more severe, like the big surgery. So just a way to say that that's one of the ways that we sort of look at what treatment's going to be good. Another way that we try to do it is, like I was talking about the medical and surgical. Is it really inflamed right now? Do I need more medical therapy to calm it down? Is it more calm, but still having drainage and needs some surgery? So there's kind of a couple different ways to look at the treatments and figure out what would be the next best step for each individual at each given time point. It's still not a perfect science, and it's still really individualized. Like the guidelines are great, but when doctors who don't have a lot of experience treating HS read them, they still go, okay, so I'm not really sure when I see somebody, like, what is my first step? So we kind of go into the thing, like when I'm teaching them, I say, all right, here are some of the good first steps. I always give people this and that, and then we work on this or that. But it's a good guideline to have. So we'll talk about some of the treatments, starting with something we call lifestyle modification, which lifestyle modification is kind of a funny word we use in medicine that means not medicine, not surgery. It's the other things that are happening in your life. So the basic idea behind it is you figure out the things in your life that make your HS better or worse, avoid the things that make it worse, move toward the things that make it better. Sometimes it has to do with clothing. Oh, and I forgot, I put the little detective here because this is the place where patients playing detective a little bit can be really helpful. And there's two ways to play detective. One is just pay attention to your body, listen to your body, pay attention to what makes you better or worse, what seems to trigger a flare, whether it's something in the diet, your clothing, stress. The other way is to connect with other patient organizations and other patients, because as much as I can learn about HS, without living with it, I will never know as much about HS as someone who's lived through it, especially when it comes to the lifestyle things, because these are the everyday things that living with HS teaches you. How to dress your draining wounds so that they won't show through your clothing, how to pack extra bandages in your bags for the airport, what to do in this situation, that situation, how does diet affect things, what exercises can you actually do that aren't going to just create more friction and flare up your HS, what foods tend to make it better, what can you do when you have a painful lesion and you're at home and it's the weekend and you don't want to go to the ER because it's not that helpful when you go to the ER, what are some things you can try at home. So sometimes this entails clothing, finding clothing that don't flare up your HS, whether it be loose fitting, snugger fitting, different types of clothing, how does smoking affect things, activities, whether they make your HS worse, or if there are some that sort of make it better, things you need to avoid, even activities when it comes to, being intimate with HS. That's a big issue. So learning from other people about intimacy issues, or even talking to a counselor about it can be helpful. We talked a little bit like weight loss, diet. Diet's one where I'm so glad that Jillian's going to be talking about and studying diet in HS, because I think we have a lot more work to do in general when it comes to diet and disease, but especially with HS. I feel like diet plays a big role for a lot of people, and it's so hard. Like when I talk to people about their diet, I say, all right, we know the Mediterranean diet or the anti-inflammatory diet seems to be helpful for quite a few people, but it's so individualized. For some people, dairy seems to flare up their HS. For other people, it makes no difference. So I tell them it's another one where it's kind of trial and error. You've got to, learn about your disease and your HS and what bothers it. And then vitamins and supplements. There's even some vitamins that have been studied as a medication for HS. And then wellness and stress management. Like Jasmine was saying before we got started, if there's a big burden of anxiety and depression and stress that comes with HS and living with it, and it just kind of constantly being there. So it's important to be able to recognize that impact, deal with the stress of it, do things to lessen the stress, and to focus on the things in your life that are positive, even when the HS is trying to steal your joy. Then the medical treatments, these are the ones that are sort of the most well studied, and we're studying some more. You can kind of break them down into topicals that go on the skin. So there's your washes like chlorhexidine, or the brand name is Hibiclens, benzoyl peroxide, Perithione zinc, which is in Head and Shoulders and some other soaps and shampoos, dilute bleach baths sometimes people will use. And then a prescription antibiotic called clindamycin comes as a liquid or a lotion. And there's one called resorcinol that is hard to get in the US because it's not available commercially, but sometimes you can get it from a compounding pharmacy, and it's more popular in Europe where it's easily available. And then we use a lot of antibiotics in HS, and I think that sort of contributes a little bit to some of the confusion about HS, because people say, well, you treat it with antibiotics, it's an infection, but it's not contagious. And if you reduce your immune system or suppress your immune system, it gets better. So those are two clues that it's not just an infection. There's more going on. And sometimes when we use antibiotics, we use a lower dose where they don't even affect bacteria. They just affect the immune system and calm it down. So I listed some of the antibiotics here that have some evidence to help HS. And sometimes it's a combination, sometimes it's short courses. And then I list here a few of the hormonal things that can help. Often we use these more in our female patients, but sometimes in male patients as well, especially like contraceptives is another word for birth control, or spironolactone is getting more popular as things that sort of alter the hormones or the way they affect the skin and can help HS. And then we have some things that help that stop the immune reaction that we talked about. So prednisone is good for short term, not great for long term because of side effects. And then I mentioned those vitamins, zinc and vitamin D have both been shown to kind of support the immune system in a way that helps HS. And then we have our biologics, and the biologics are these medications that usually you have to either get by injection or infusion, and they're actually antibodies that block part of the immune system. And so what we've done is we've discovered parts of the immune system that are overactive in HS, and then we have these antibodies to block them. So adalimumab is one out there that's approved for it. Infliximab sometimes helps. They have these big challenging names. And then we're studying more and more to see which ones will really help and really work for HS. And then when it comes to the surgical side of treatments, You can kind of break surgery down into local, so just like that area or that spot, like one lesion, regional, which is sort of the area, and then the others. So locally, you can do a steroid injection. So a lot of times we'll do this in the dermatology office. If you have a flare up, give me a call, we'll get you in, we'll inject some steroids. Usually in a day or two, it kind of calms down the inflammation. Incision and drainage, which is also called lancing. That's one that we're not as big a fan of. It does provide some temporary relief. So that's where you sort of open up one of the abscesses, allow the fluid to drain out, and it sort of gives some relief to the pain. The bad side about it is they always come back. So it doesn't actually address it long term. It's very temporary. So sort of the one step above that is what we call de-roofing, where if you think of it as sort of a little tunnel or a little pocket under the skin, we take the roof off and we let it heal in from the bottom and it scars over. That's much more effective at making sure that that spot doesn't come back. It only helps the spot that you actually took the roof off of, but it's nice for that spot. So where we're trying to push people to stop doing the lancing or the IND, incision and drainage, and instead just take the roof off. It's only a couple more steps, not much more involved, and then that spot won't come back in the future. And then there's also local excision. So this would be, excision means sort of removal. So this is where if you have sort of a area that's scarred and has some tunnels, I might take it out and we numb it up. And then we might use a CO2 laser, which is a laser that sort of cuts the skin and it stops bleeding as it cuts. So if you think of the kind of laser that they were going to cut James Bond in half with, it's sort of like that, but medical strength and safe to use. But it's a laser that kind of cuts through things. Or you can just use the old-fashioned scalpel or other surgery tools, and you just kind of go around that lesion and the spots around it and remove it. And then we like to let it heal in from the bottom, which I'll talk about in just a second. And then regional surgery is also known as wide excision. So that's where if you have really advanced disease and it's sort of taken over your armpit, they might remove all that tissue. So it looks like you basically kind of took all the skin out of someone's armpit. And a lot of you may have seen some pictures of this online. I always warn my patients, it can be scary if you have a new diagnosis of HS and you start looking it up online, because you can see some very severe disease and some very drastic surgeries. And you can use the same tools. So the local excision and wide excision are sort of the same surgery. It just depends how much you're taking out. So generally it's matched by how advanced the disease is. If the disease is already sort of destroyed a whole area of your body, they take all of it out. If it's more spotty and just parts of it, then you just try to take out those parts. And then I also mentioned here, there's something that sort of falls under a surgical treatment is laser hair removal. So there's actually some studies that have shown laser hair removal can help clear up and prevent HS. So it's just the same kind of laser hair removal you get if you don't want hair in your armpits or in your groin. But it seems to help the HS by sort of causing, it gets rid of the hairs. And like we saw earlier, we think that's where everything kind of starts. For some people, it gives really long lasting results. For other people, it lasts shorter amounts of time. And it's like everything, it doesn't work for everybody, but usually when it works, it usually does give you a pretty good break from the HS for a while, and maybe even permanently. It's a struggle right now because insurances don't usually cover it because they view laser hair removal as a cosmetic procedure. So that's another area that we're trying to get them to understand that for HS, this is an actual treatment. And then I just mentioned here too, that when it comes to surgery, there's different things you can do when you're done with the surgery. Like once you've removed the HS lesion, what do? So you can sew it up like you would other kinds of surgery where you remove something, or you can do a skin graft, or you can do what we call secondary intention, which is letting it heal in from the bottom. It takes a little bit longer because you have to really let it heal from the sides and the bottom, but it's actually the best in terms of recurrence or disease coming back. The worst is sewing it up. So we think when you sew it up, it sort of puts that skin on skin and just creates an environment that HS likes to come back in. So the best is letting it heal in, even though it's kind of the longest journey to healing and the most healing time. Skin grafts are in the middle. They aren't as bad as sewing it up and in terms of it coming back, but they're not as good as letting it heal in from the bottom, but they are a little bit easier and quicker for the healing process. And sometimes people will even sort of, if there's a big wide area that they want to do, like the whole armpit, they'll do it in more than one stage. So there's a lot of different surgical treatments and sort of options, and different physicians are more familiar with one or the other or all. Some people do some and not the other. So I do some CO2 excisions in the office, but I don't go to the operating room and do the really big surgeries. I have a plastic surgeon I work with who I share cases with, and we collaborate on those ones. I do a lot of de-roofing in the office, and we're trying to get all dermatologists very comfortable doing it because it's a big service that we can offer people and it's not that difficult to learn. And then I just wanted to put another little slide up for one of the other aspects of management in HS and treatment is the pain management. Like I said, the pain is a really big problem in HS. Over half of patients report living with moderate or worse pain, so like a 5 or more. And about 5% live at a 10 out of 10 pain. That is just their baseline HS pain is 10 out of 10. And we think there's sort of two different kinds of pain in HS, one that's due to tissue damage and then one that's due to nerve activation. And there's sort of new research going on in this area to see, what treatments can we offer beyond just our old-fashioned pain pills. So when it comes to pain management, step one is always trying to get the HS as calm as possible. Because if you can shut the disease down, often the pain goes with it. And then you can try to use over-the-counter painkillers, which, as people are probably aware, there's a big push right now to avoid the addictive painkillers, but sometimes you got to use them. Sometimes they're the only thing. And then these are some of those other drugs that I mentioned that we're sort of looking into, is things that are more helpful for the nerve type pain, like neuropathy type medications, like one called gabapentin or pregabalin. And then I work a lot with a pain management specialist because I'm not an expert in pain. So I work with someone who is. And then I just put up a little picture here. We're actually doing a trial right now in Detroit. So if you live nearby and you have pain with your HS, let me know, of battlefield acupuncture, which is a specific kind of acupuncture using the ear and these little tiny needles that actually stay in for a week that look like a little earring stud, because it's been used in other fields for back pain and for surgical pain. So we're trying to see if this would be a good option for patients with HS to see if it would help to get rid of the pain. So I'm very hopeful that it will work because it's been really great in other fields for avoiding pain medications, but also getting people's pain under control. And then I'm wrapping up. I've been talking too much already. Just a little bit about research. So research gets me excited. I love research. I think our strongest weapon against HS is knowledge. And the more we can learn and know about it, the more we can fight it. In 2007, in the medical literature, there were 49 articles the whole year published on HS. In 2020, there were 654. So it went from being this disease that nobody was really studying and talking about and not much was going on to a very hot topic and a hot area of research where people are really diving in and trying to figure it out and spending time and money and resources and pouring their hearts out to try to help people. And that is so inspiring to me. And I'll tell you, that's why I love being involved with the HS Foundation, is because the board is made up of passionate patient advocates and physicians who just want to stop this disease from damaging people's lives so much. And they are always inspiring me and they're so supportive and it's just so great. And there are such amazing minds working on HS research that I know together we will be able to succeed. And then I just put down here, these are some clinical trials, and clinical trials happen in 3 phases. So the first phase is 1, and then 2, and then 3 is kind of right before it's ready to come to the market and be available. And these are all the medications that are under clinical trial right now for HS. So it's kind of exciting. Right now, there's 1 FDA approved medication in the US. These ones are all on their way. So this is kind of exciting news. And right now, there's a little bit of a sort of Me Too movement with HS where we found drugs that are useful for psoriasis and we say, hey, let's see if they work in HS. But I'm excited because there are actually some drugs coming out that are designed just for HS based on the research we've done, which is great. I mean, it's great when a drug works for more than one disease, but it's even better when you find something that's really specific to your disease, and a lot of times they'll work better. So I'm very, very hopeful that we're going to have better treatments that are safe and effective. And I would encourage you, I know sometimes research is a little difficult because nobody wants to feel like a guinea pig where they're trying stuff out and testing things on you. But I will say the HS community of patients has just inspired me when it comes to research, because I have met so many people who are so dedicated to advancing our knowledge of the disease and like encouraging research and helping spread the knowledge about research opportunities. And it's just such a wonderful community of people who are with us battling this disease. So if a research trial is appropriate for you and available to you and you're kind of nervous about it, I would say just try it out and at least talk to the researcher, because you'll probably be inspired at their passion for wanting to end HS and make the world a better place. So with that, I will kind of wrap up and end. And if you have any questions, I am so happy now to just talk and try to figure things out. And hopefully I know the answers, but if not, I will do everything I can to answer.
Thank you so much for sharing that amazing presentation. We have tons of questions, but before I went to get into the audience questions, I wanted to clarify some things that came up within the presentation. For bleach baths, I don't know if there's any other patients who feel this way, but I know when I was told to do a bleach bath, I was worried because there's research that shows that bleach coming in contact with skin can cause cancer. So can you speak to that? And then also basically the safety of bleach baths for the skin and effectively helping to lower the inflammation and whatnot of HS.
Yes, excellent questions. So it's kind of funny because I feel like even the word bleach is a little bit scary. So we use a lot in dermatology. We actually sort of started using bleach baths for eczema, where people get really itchy skin and they have a higher risk of infection. And so we like it because it kind of wipes out some of the bacteria on the skin. And like you mentioned, Jasmine, it actually has a little bit of a calming effect on the skin and on the immune system in the skin. So sometimes what we'll do is, instead of calling it a bleach bath, we'll call it a swimming pool bath, because chlorine in your swimming pool is chlorine bleach. And so it kind of helps people to know, like, oh, wait, I'm just making my bathtub into a swimming pool by adding a little bit of chlorine to it. And so that way it doesn't seem as scary. And at those concentrations, we haven't seen the risk of cancer that we see with like the more concentrated bleach coming into contact, which is really good. And especially for anybody who's on the swim team, totally okay to swim in the swimming pool. And sometimes even if patients can swim or have access to swimming, like a swimming pool, not so much a lake because it doesn't have the chlorine, but a swimming pool, I tell them you don't even have to do a bleach bath. If you can go in the swimming pool once or twice a week, that's a bleach bath.
Absolutely, absolutely. And along with that, you were talking about antibiotics. You kind of segued into that conversation. Um, Antibiotics is also a concern. I know of some patients of becoming resistant, and especially taking them because HS is not a bacterial infection. So can you speak a little bit to that and sort of help to lower some of that fear that some patients have while taking antibiotics, and some patients who are actually knowledgeable about what antibiotics can do to the gut as well, in the imbalance there?
Yes. And those are really, really good points. And I'll be honest, I don't love giving antibiotics for those very reasons. It can be hard on your gut. Our gut are full of great bacteria that support our health and help us. And that's kind of the whole thing with probiotics and prebiotics, is supporting your gut bacteria. And then you start taking an antibiotic and it kind of throws things off. And one that we use for HS is clindamycin, which is very well known to cause problems in the gut. Luckily, we often combine it with rifampin, which does help to balance that risk and lower it a little, where the risk is that it's going to kill the good bacteria and then the bad bacteria will take over the gut and cause more problems. But it is a risk. So we try to keep antibiotics to as short as possible, and we try to only use them if they work. Sometimes with the ones, especially the doxycycline and the minocycline, we can use a lower dose where it doesn't seem to affect bacteria as much, but still affects the immune system and calms it down. Mm-hmm. It's sort of interesting because every time I think I know what I think about bacteria in HS, something else comes out that changes my mind. Mm-hmm. So there's a medication called Erdopenum that's an antibiotic that you can only get IV. So sometimes we'll give it in the hospital. Sometimes we'll have patients go home with an IV to get treatments for 6 to 8 weeks at home. It works amazingly well for HS while you're on it. Once you stop it, it doesn't work so well. So we sort of use it as a bridge to something else. Before your surgery, I'm going to get it calmed down with this. Or while we're starting these other medications that take longer to kick in, let's start Erdopenum. It does not affect the immune system at all. It only affects bacteria. So when that started working so well, it kind of changed my mind. I thought, oh, these antibiotics are just affecting the immune system. The bacteria doesn't matter. But then this one comes along and it's like, oh, well, it seems like if we get rid of those bacteria in HS, then it does seem to calm the immune system down. So it's a really complicated issue. Sometimes I will have patients sort of try to make sure they're taking a probiotic with the antibiotics to support their gut health, or if they like yogurt and dairy doesn't flare their HS, just eat a yogurt every day to try to balance that out. There was also a really interesting study that found your gut is supposed to have a lot of different bacteria, and those bacteria basically eat what you eat. So our food goes through there and they eat it. So if you eat 30 different plants a week, it supports a very healthy gut microbiome with lots of different bacteria. And it sounds really difficult to eat 30 plants a week, but spices count, seeds count, nuts count. So if you have, you put some thyme and rosemary and sage, those are all 3 plants. So it's a good way. I try to tell them, make sure you have lots of plants in the diet and sort of have variety. Don't be like me when I was in med school and I would cook enough chicken and broccoli to last me the week and eat chicken and broccoli every night for dinner. Switch it up and try to get different plants. And then honestly, always just talk to your doctor too about your concerns with the antibiotics, because there may be some other options that they can go to, like the spironolactone I talked about is more of a sort of hormonal treatment, and maybe that would be a better choice. The zinc is one that doesn't really affect bacteria and may work, although I will say that the zinc can have some stomach side effects and cause a little bit of nausea and even diarrhea too. But it's always kind of that balance and finding what's right for you. There's also, I'll put a little plug in, there is a nice tool out there on a website called Inform Med. That is a HS decision tool. So it's decision support tool. So it's this tool where you can kind of put in some of your preferences. And it asks you some questions about how you feel about different treatments. And then you can bring it to your doctor and it kind of helps to say like, okay, this is what the tool said, maybe some good treatments for me. And it was developed by a doctor who's right next to Detroit here in Windsor, Canada. And it's just kind of a way for you to, and it even helps patients to like understand the treatments and, say, all right, I don't really like those side effects. So maybe that one's not for me. Maybe this one's a little bit better. So it's not for everybody, but it's kind of a nice tool to check out and see if it can help you out a little bit and help to have that conversation with your doctor about, well, maybe this isn't the treatment for me. Maybe it is. But yeah, antibiotics are kind of a double-edged sword. I like when they work. I don't like when they cause problems.
Absolutely. And I kind of want to go back to you were clarifying some of the myths, and I wanted to make sure that I clarified that while HS can be aggravated by gaining weight, it's not caused by gaining weight. So right. I just want to make sure that we understand that, because I know that can kind of be confusing. So you didn't get HS because you're fat. Okay.
Exactly.
But if you are large and if you do have fat and then you are continuing to gain weight, it can get aggravated by the condition. Okay.
Yeah.
So, and then too, I also wanted to, before we dive into the questions, can you talk about the difference between a cure and a remission? Because I think that is something that is very confusing for a lot of people. And I understand it, as, remission is something that goes away temporarily and you can keep at bay. Cure is completely gone. So if you could dive into that and clarify it a little bit more, that would be awesome.
Yes. And it's funny because I always bring that up with our residents. And I tell them, you need to let patients know what to expect. Because when you go to the doctor and you get a treatment, it just naturally you think like, okay, I'm going to finish this course of antibiotics and this will never be a problem again. I have strep throat. You give me the antibiotics, the strep throat goes away. I don't have strep throat anymore. But like you said, These are chronic diseases where there's remissions, where things are doing better, or maybe they're even under control. So that's another thing I say a lot is we can't cure this disease. We want to control it. And once we have it under control, as long as we keep those treatments going, hopefully it will stay under control, but we can't stop the treatments because it will probably flare back up again. So I always tell them you have to set people's expectations with that, because otherwise you go to the doctor, you expect a cure. You give me this and I'll just be better and I'll stop using it and I'll be good for life. And unfortunately, we are not there with a lot of diseases, but especially HS. We can do our best to get it under control, get it into remission. And it's an interesting disease too, where sometimes even on its own, it will sort of go into short remissions or even longer remissions. But it's really hard to rest easy and think like, okay, my HS is done. It just doesn't work that way. You never know. Even surgery, we sort of look to surgery to be sort of the cure, because surgery is often good at curing the spot that got the surgery. But as a lot of people will tell you, around the surgery, you can still get a flare up. You can still get new lesions. It doesn't mean that your HS is gone just because they cut out every single part that was there today. You may get new spots. So it's even hard in that sense that even the things that you think cure, like if you remove something surgically, it is cured. Well, not HS. That one spot is cured, but the spots around it are still at risk. And a lot of times we'll even keep medical treatments going after everything's removed and kind of try to keep it under control.
Absolutely. And I kind of wanted to chime in a little bit with my personal story, because I think this is a great example of like a segue for this, in that when I first was diagnosed with HS, I was 350 pounds and I had stage 3 HS, and I lost over 150 pounds. And my HS eventually went into remission due to some diet changes, exercising, and different like chemical like buildups and things like that in my body, like collagen, I think had contributed in some way to my HS healing. And so years later, I continued to sort of like eat the foods that I found out were my triggers, like dairy and yeast and breads and things of that nature. My HS came back. And so I think that is a perfect example. And I thought at that time I was cured because I didn't have the education that I have now. But that is a perfect example of, where we can be and where we can go. So even though there's not a cure, remission is possible. And it takes time. And even for me, last year, compared to me right now, I was completely debilitated from HS. Couldn't get out of bed, anything of like that. So if there's any hope, I'm here and I'm able-bodied at the moment. Who knows what tomorrow holds, but there is hope for remission. So I just want to give that piece to the patients that are tuned in. Also, starting into the questions that we have from the attendees, Crystal asked, would Humira be an effective treatment for HS? Can you speak to that?
So it's kind of interesting. Humira is also known as adalimumab. It is the one FDA-approved treatment right now. There's probably going to be some more before too long. And they did this trial where they gave some people Humira and some people the placebo, where they weren't getting a medication, and then they kind of compare, all right, what's the difference between the groups? And it's really hard to study how is HS doing. Like we study psoriasis, you look at someone and you can say what percentage of their body has psoriasis and how thick is it? HS is hard because you get lesions, they come and go. Is it a good day, a bad day? So they made up this thing called the HI score, which is just a way to kind of count the number of spots you have for HS and see if they got better. And they decided that a 50% reduction in lesions would be considered a success. And about 30 to 50% of the people in the trial got that, more closer to the 30 end of it. So it was still sort of an ineffective treatment, but I always kind of tell people, don't get excited like we're going to start this Humira and you're never going to have another flare up and never going to have another spot. Because if you think about it, the target we kind of decided was a good treatment was 50% better. So even that's not great. Having said that, some people do really well. Some people do kind of clear up on it. Other people, it does not work. For 70% of the people in the trial, it didn't work great. So it can be a good treatment. The other thing to remember with the trials is they did 2 trials. For the first one, that was the only treatment people could have was Humira. For the second one, some of the people were still allowed to take doxycycline or minocycline antibiotic. So that's where I was kind of talking earlier, where a lot of times we need combinations of stuff. We don't rely on one thing to improve it. So if the Humira can get you 50% better, maybe I can do some vitamin D with it, or some zinc, or some spironolactone to kind of get us the rest of the way. And maybe I can use some washes, and maybe we can find some other things. So it's hard because technically it is an effective treatment, but I always kind of tell people, like, with all treatments with HS, you just kind of have to be ready that it's not very often you hear somebody who's like, oh, I tried this one thing and it was perfect, I cleared right up. It's more like, oh, this one kind of helped me. Then when they added this, it was good. And then we did this and changed this. And it's a complicated disease, and we don't have like a single treatment that's great. But I'm really reassured that they invested in bringing that drug to market for HS. Like it costs a lot to do a clinical trial and to get a medication out there. And so I'm glad that they did it, and they kind of brought a lot of attention to HS. And then these other companies were like, hey, maybe we need to get a drug for HS. Let's do some research on this. So I don't want to like talk bad about it, but I always kind of set people's expectations that it's not like a great, this is the best treatment in the world and I don't need anything else. Sometimes too, what's really tricky with HS is, like I was talking about with the fire and the damage, is even if the Humira can really control your inflammation, you may still have some tunnels that are draining that really just are only going to respond to surgery. And in the trial, no surgery was allowed. So they didn't have a good way to capture that too. So it's just a very complicated disease. So I think it is an effective treatment, but I also don't want it to sound like, oh, it's the best thing out there and you're going to love it and it's going to be great. So we just don't have that yet, unfortunately.
And another example from my own personal life, because I like to interject myself, but no, this is seriously relevant. But in my case, is speaking to what you just said, when I lost all the weight, some of my areas in my body did go into remission. So for an example, in my breasts, my back, my sides, the HS, the scars are still there. You can see them, but no tunneling, no tracks, no nodules exist. However, on my armpits, I had so much scar tissue and tunnels still going on. So I got CO2 laser under both of my armpits to remove that diseased skin. So that's a perfect example of, diet or, a medication working, but they're still needing to go in with the carpenter and the individuals to come and fix, the things that are, wrong topically with your skin as well. Going into the next question, Sandra asks, if HS starts with follicular occlusion, does exfoliation, mechanical or chemical, play any role in HS prevention?
So it's kind of funny because I thought the same thing when they were like, oh, it's the hair follicles getting plugged up. We even have acne medicines that are in like this retinoid family, like Retin-A is kind of the most famous one, that they keep the pores from getting plugged up. Because in acne, they kind of say, oh, that's the same thing. Like the pores and the hair follicles get plugged up and it causes a pimple. They don't work so well for HS. And sometimes exfoliating can even cause it to flare up because it kind of triggers more of the inflammation. So we say that the hair follicles get blocked, but I don't think they get blocked right at the surface. I think it's a little deeper down because it seems like the surface things we do to try to keep them from blocking don't seem to work so well. And I didn't mention it too much at that point, but there's even been some studies about the oil glands. And there's this part where like your hair follicles coming up to the surface and the oil gland connects to put the oil onto your hair. And they found that the spot where it connected was thinner and weaker in patients with HS. And they said, it seems like that's where that first rupture begins. And they said, it's deep enough that like acne, you get a pimple and it's right at the surface. Like that's why people pop them right in the mirror. HS, sometimes they don't ever come to the surface. Sometimes it takes them forever to get there. Sometimes you think they're at the surface and it's just deeper. And like the whole thing is happening at a deeper level. So I think the hair blockage is also sort of a under the surface issue, even if it's sort of near it. So the surface treatments don't seem to really help. And like I said, just be careful, because for a lot of people, the like if you try to exfoliate aggressively, because it kind of removes a lot of skin, that will trigger more inflammation to show up and actually flare it up.
Absolutely. And even with that, would you say that, oh man, I'm sorry, my question just evaporated from my mind.
That was
Um,
me all day today.
Lord. Okay, it'll come back to me, but I'm gonna go into the next question because that was really great information. Because I know there's some products out there, and I won't speak to any specifically, but there are some products out there that are claiming cures to HS, and some of the products are calling for exfoliation, aggressive exfoliation of the skin, sort of like what you were speaking to, Dr. Daveluy. And I just want to encourage patients to not buy those products because that could make your HS a lot worse. So just be very cautious with people. Stay away from anyone who says they have a cure for HS. I think we should start there.
Yes,
So
yes.
stay away from anyone who says that, and then I think you'll do very well on your journey.
Yes.
Going into the next question, Angela, she said, I recently posted a how it started and how it's going image in a Facebook group. It showed a small epidermoid, I think I pronounced that right,
Perfect.
cyst that had been there for quite a long time with no problems, then showing the abscessed state. So many surgeons have told me that those cysts are not HS, but they almost always do inflame. Are these the cysts
Yeah.
more prone to abscessing in people with HS? Does this propensity to inflame justify having them surgically removed prior to inflammation?
Really good question. Really tough answer. So epidermoid cysts are kind of like the classic cyst. If somebody doesn't have HS, but they just have that like cyst on their back, and it's just that lump under the skin. Sometimes you can even see like the opening or the pore, like a little blackhead on it. So I always think it's like your uncle when you're having a cookout and swimming and stuff, and you're like, "What's that lump on your back?" He's, "Oh, it's just a cyst." So those can just pop up kind of in anybody. Um, Sometimes people get more than one. A lot of people just get the one. We call it epidermoid because the epidermis is the top layer, and they're kind of lined with skin that's almost like the top layer. And then because our skin's always shedding, they build up like dead skin inside. And like you said, they can rupture and sort of become this abscess where then it triggers inflammation. Sometimes they never do. People go through their whole life with a cyst and it never does that. Other people's, for some reason, do it more often. What's really hard with HS is was it Angela who asked?
Mhm.
It's like she mentioned, it's really hard to tell the difference between this epidermoid cyst and a cyst of HS. Sometimes you have those little clues like, oh, the epidermoid cyst almost feel like there's a little ball that moves around under the skin when you kind of mess with it and feel it. And HS doesn't usually move around like that because it's more like in the tissue, but they're really hard to tell apart. So there haven't been a lot of good study on it because it's hard to say like, oh, that's your epidermoid cyst and that's your HS, especially if it shows up in one of your locations where you have HS. So unfortunately, I don't think we really know for sure one way or the other. The general rule with epidermoid cysts is we say, all right, if it doesn't bother you, we don't bother it. If it hasn't become painful, red, swollen, it may never do it. So it's not really worth going through the surgery and having it removed. If it does, then maybe it's worth it. Definitely, if it keeps doing it, it's worth getting it out. So that's kind of one approach that would still apply even if you have HS. If you aren't really sure if it's an HS lesion or an epidermoid cyst and you're kind of willing to undergo the surgery, it probably would sort of reduce that risk that it's going to flare up and become an abscess. But I can't say 100% because, like I said, we haven't really studied it too well. So you could sort of apply the general rule. If the cyst isn't causing you problems, let it be. But when it starts causing problems, time to go. And sometimes after they turn into an abscess, the epidermoid cyst will actually go away. The body will kind of like eat the whole thing up and get rid of it, which can happen with HS too. Sometimes you get an abscess and then it doesn't come back. Other times it just keeps coming back.
Mhm, mhm. Absolutely. Stephanie asked, I take 90 well, she said I take 90 milligrams of zinc daily. What is a good dose of vitamin D to add to the regimen?
Yes. So the vitamin D studies were pretty interesting. Most of them, what they actually did was tested vitamin D levels in the patients first. And they found that a lot of people were vitamin D deficient. Depending where you live in the country, a lot of people are vitamin D deficient because you can get it from the sun or from diet. So like I'm in Michigan, there's like 8 months out of the year, we don't even have enough sun to get vitamin D from it. So they tested people first, and then based on their vitamin D level, there's sort of two ways to supplement. So for most adults, 800 IU, which stands for international units, is like the normal dose of daily vitamin D. Some people will even round it up to 1,000 just to make it easier to remember. But if you're really low, there's actually these other ways that they'll kind of get more on board quickly. So you might take 50,000 a week to get back up to normal, and then switch over to the 800 or 1,000 to stay at normal. The good thing about the vitamin D is almost any doctor, like your primary care, if you say, hey, can you check my vitamin D? I heard if it's low and I replace it, it might help my HS. They're used to checking vitamin D. It's kind of a normal lab. It's not one of those, strange labs that we don't check very often. So it's a good thing that you can kind of ask your doctor, like, hey, would you check my vitamin D? Definitely okay to take that regular daily dose of 800 to 1,000 a day. But it might be worth checking, because if you're really low, it'll take a long time to get up there with that dose, and you'll want to get up quicker. Vitamin D is one of the vitamins too, where it gets absorbed better from your stomach if you have some fat in there at the same time. So it's better to take it with like a meal, especially not if your meal was just like a fat-free snack or something that has a little fat in it. So like take it with your dinner, which sometimes is a little different for people. If you take your morning vitamin and you just have coffee with it, then you might want to switch and take your vitamin with dinner, where you actually have a little fat to help it absorb and work a little better.
Absolutely. An anonymous attendee asked, will all nodules always turn into abscesses? I have seen pics of people getting them on other places that are not listed in the common places. For example, on the back, is it also possible? And I think that is great to kind of like discuss some of the studies that have shown HS on the head, the back of the neck. I've heard patients say behind the ears. Me personally, last month I got some inside my ear canal. So can we talk about that?
Yes. Yes. So that is a really good point. Those are kind of the most common locations, but it can show up in a lot of places. And they did a couple studies where they looked at a big group of people with HS and sort of wrote down every possible thing they could, recorded like where it shows up, what's their sex, what's their weight. And they sort of found these 3 different groups that tended to sort of have the same findings. So they call those like a phenotype, which means like, what does it look like? What does you all have the same disease, but it looks different in you. And so they found one that was sort of like the classic. It happened in women. They tended to have higher body weight, and they tended to have it under the breasts and the armpits and in the groin. And that was sort of like the classic HS, and it was the most common one. And then they found another type where there were a lot of little like pimples around it. And so they called it like the follicular version, where like some people with HS, they almost have like, it almost looks like acne around the areas where they get the HS. And then some of them get into bigger nodules. So they said, oh, this is kind of a different type. And then some people had this sort of like severe type where it was more widespread. They were a little bit more likely to be male patients, and more likely to be either normal body weight or even low body weight, like skinny kind of. And then they have this severe type where they had it in the normal areas usually, but it would spread to the chest, the back, the neck, the scalp, like you said, the ears, down onto the thighs. And unfortunately, it tends to be a really severe type. And we don't know why people get different, it shows up different ways. We think that it might be sort of like there are different forms of HS, and maybe they're related to different imbalances in the body. Maybe some of the pimply one might be due to like the hair follicles plugging up, but maybe that severe one is more an immune system issue. And they're still kind of studying to see like, why does it show up differently? But it's a really good point that just because your HS shows up in a different place doesn't mean it's not HS. Also, HS can come, sometimes they have follicular occlusion was that word for the hair follicles getting blocked up. So sometimes we talk about these other follicular occlusion diseases. So one is called pilonidal sinus or pilonidal cyst, which is basically like a chronic spot of HS right down at your tailbone that just keeps coming back and coming back, but it acts just like HS. Another one is a really severe form of acne that looks like HS, where your face gets just this terrible deep acne and your chest and back and shoulders get it really bad. And then another one is called dissecting cellulitis. It's basically like HS in your scalp. And so it causes hair loss and these big painful nodules and cysts. And they're all kind of like HS cousins. And some people get more than one. So they'll get like 2 of them or 3 of them together. So that kind of clouds the picture too, where if someone has severe HS and dissecting cellulitis, you're kind of like, well, it's almost sort of just HS all over. So it makes it really tough. And then the question too about the nodules, not every nodule becomes an abscess, and not every abscess comes from a nodule. Sometimes you have totally normal skin and it just becomes red and swollen and full of fluid out of nowhere. So we don't really know what causes lesions to go one way or the other. And it's different for different people. You know, some people get lots of nodules and no abscesses. Some people get lots of abscesses and barely any nodules. Some people have, you know, like these are my nodules that are come and go all the time. And then once in a while I get an abscess. So it's kind of tricky. The other thing to kind of speak to on that is one study found the average length of a flare for HS was 7 to 10 days. And the interesting thing about it being 7 to 10 days is if you go to a doctor who doesn't know anything about HS and they think you have an infection, they give you 7 to 10 days worth of antibiotics. You're like, oh, it kind of got better. And they go, yeah, I told you it was an infection. It got better. But in reality, it was just going to do that anyway. That's just how long a flare of HS lasts. And so it kind of confuses doctors and sometimes even patients that like, oh, well, I think it was an infection because I got, you know, a week of antibiotics. And by the end of the week, it was doing better. Well, it probably would have done better if you didn't have the antibiotic, unless it's one of them that does help HS. But a lot of time it doesn't. It was just a kind of a coincidence, which just kind of makes it even tougher that I feel like the disease is just trying to throw us another curveball.
Absolutely. And before we get into the next question, because I think that this is a great segue into that, I just want to make sure, because we only have a few more minutes left, that it's okay to keep going through a few more questions because I want to respect your time. And then I know also some other attendees probably have some things to do. So I guess this is sort of like a soft dismissal in a sense, unless Dr. Daveluy, are you okay with answering a few more questions?
Totally.
Okay, yeah. So if any attendees need to go, we completely understand, but we are going to answer, sorry about that, a few more questions before we end today's summit. So the next question comes from Bianca, and she is asking, what are the statistics on laser hair removal and what is the success specifically for HS?
Great question. So the one that's been studied the most, there's sort of 3 lasers that do hair removal, almost a 4th one, but 3 that are really popular. One is called the ND-YAG, Y-A-G. One is called the Alexandrite, and one is called the Diode. And so they're just different forms of laser, and they have like these crystals in them, and they put energy through them, and that's what makes the laser beam. So they're a little bit slightly different. And the reason I bring it up is the ND-YAG is the most well studied. It had the biggest trial so far. It works pretty well. It was a little bit different for different body regions. So it seemed to work the best under the breasts, not as well in the groin, and in the middle in the armpits. It was around like 30 to almost 50% of people responded. So it was a pretty good treatment. What's interesting is, again, like I kind of talked about with the Humira thing too, you make these trials, and when you make a trial, you really try to make sure like, okay, this is the only thing that's going on and the only treatment we're doing, and we're making sure so we can just see how well this treatment does. So a lot of times it's the same story. If you kind of combine it with other stuff, it can help a lot. We do the laser hair removal. We use the Alexandrite, and we're actually studying it to kind of put a publication out on it to show it works pretty good too, probably just as well. And we noticed that a lot of people might flare after the first treatment. And we think it's because the laser is kind of getting in there and disrupting things, and then they got to come to the surface. So in the trial, it's just the laser. But in real life, I try to have people on a little course of antibiotics or something else to help out during that time so it doesn't flare as much. There was even a study in Germany, and they used that same IndiYag laser. And their idea was, let's see if it prevents HS. So let's take people with mild disease, Hurley stage 1, and do laser hair removal and actually try to remove the hair. Because in a lot of the studies, they would just do like 4 or 5 treatments, even if it didn't actually work to remove the hair, just to see if it worked for the HS, and it did. So they said, let's remove the hair. So that was their goal, is to actually do it as if you were going there just for hair removal. And they found that it was actually pretty effective at preventing HS and getting it to kind of calm down and not progress, which is kind of a big deal. Again, the hard part is sort of getting the insurance coverage for it. If you have the means, it's a good option, but I know it's not for everybody. It can be kind of expensive to get it if you're just paying out of pocket for it. The other challenge that sometimes comes up is if you go somewhere and they aren't familiar with HS, they may not think that they can treat the areas. You know, they get scared. They're like, you've got something going on. I don't want to make it worse. I don't want to do the laser hair removal there. So sometimes I've had patients who reach out from other places in the country, and I'm like, I will talk to your dermatologist and walk them through that it's okay to do it. It's going to make it better, you know, because that's a challenge too. And we're trying to really push and get it more widely known, because a lot of areas have the hair removal lasers. So it could be a good treatment that's sort of available. And we're really pushing the insurance companies to cover it, because compared to some of the other medications, it's pretty affordable for the insurance.
JT asks, does long-term infusion treatments affect the immune system over time as well? And should it be stopped at a point if you can't get it under control naturally?
So it kind of depends what the infusion is. Like that Erdopenum I talked about, it can have more side effects if you were trying to do it more long-term. So that's why we just use it for short-term. Like it can actually weaken your tendons, which isn't great for the bones and for your body. Some of the other ones, like the infliximab, which is in the same family as Humira, it has been shown to be safe to be on long-term. And it actually is a little bit of a risk if you stop it and try to restart it. Sometimes your body builds up an immunity to it and it doesn't work as well. It does sort of affect your immune system if you're on it long term. So a lot of times the people who end up being on long term are the people who aren't having any side effects. They're like, nope, my body doesn't seem to mind having this stuff on board. Things are doing better. It is always a great idea to explore all the options: diet, lifestyle change, anything you can do to combat the HS. You know, like with Jasmine's story with the weight loss, that's phenomenal. Like try to do everything in your power, but sometimes you just need medications for it. And I always tell people too, don't forget that HS has side effects if it's untreated and uncontrolled. You know, like it does damage, it does destruction. It actually, like we were talking about those comorbidities, because of the chronic inflammation, HS actually increases your risk of a heart attack later in life and of a blood cancer called lymphoma. It's not a huge increase in risk, but it's actually like statistically significant, more than someone who doesn't have HS. And they think it's because the HS is affecting your immune system. Your immune system is overworked and just gets fatigued and makes mistakes. So I always kind of tell that to people too, if they're a little leery of the medications, as I say, you know, don't forget the medications have side effects, but the HS untreated has them too. And it can do damage to you, you know, it's wreaking havoc. So you got to figure out the perfect balance for each patient for, you know, what suits what you need, but also don't forget that it's doing damage in there too.
Mhm. I just want everybody to take a collective breath. I know it's a lot of information, and I know that there's probably a lot of things swirling around in your brain if your mind moves like mine. You know, you're just thinking about all of the things that you could possibly get into and what could possibly help and things like that. So just know that you're in the right place and that all the resources are here. Okay. That actually gets into my next question, which is about fatigue. And has there been any research as like studying fatigue as it relates to HS and sort of combating that?
So there is, I'm happy to say, it's in some early stages, but there's a group that's looking at fatigue and HS. How do we measure it? And the reason we kind of have to know how to measure it is because then we know how to study it. So they're sort of right now in the phases where they're looking at how has fatigue been investigated in other diseases known to cause fatigue, like rheumatoid arthritis is sort of a classic one, or lupus. These things that just do run your body down and cause this fatigue. And I think it's really important work for a couple reasons. Is one, we need to know that our patients are experiencing fatigue. We need to know if treatments are helping it. And it's even possible if we're able to measure the fatigue from HS, there might be a treatment that doesn't work really great for HS, but actually really helps the fatigue. So once in a while we have that where, like this medication doesn't seem to really help the overall disease, but it helps like one part of it really good. So there's this other disease that we study that you get sores in your mouth and you get arthritis and all these other problems. And there's one medication that really shuts down the mouth sores. It doesn't do a lot for the rest of it, but it does that. And that's really helpful because some patients are like, well, everything else is doing good except the mouth sores. So then if we could find one of those treatments and say, hey, look, we showed that we can measure the fatigue and this medication really helped the fatigue, that'll help the patients who are like, I feel like overall I'm doing good, but my fatigue is still knocking me out. And I will say kudos to the group. I'm not directly involved with the group, but I'm kind of in a bigger group, the group who's studying fatigue. Fatigue is hard to study. It is hard. I mean, I'm sure a lot of people with the HS who have tried to explain the fatigue. It's hard to explain the fatigue. You're like, it's just this feeling run down and drained, and it comes and goes, and it doesn't always flare at the same time as my HS. And sometimes that is a flare of HS. It's like my fatigue is worse, and that's the only thing that's flared up with it. So fatigue is tough, and I think we don't have a great way of studying it. It's kind of interesting. There's these different hormonal things that have to do with fatigue. And so you guys might have heard of like burnout. Burnout's a really big issue. Doctors are getting burned out because it's just so hard to practice medicine lately. People are getting burned out. The pandemic has caused huge burnout. There isn't really a medical definition of burnout. We don't really have anything we can measure for burnout, but like everybody knows that it's a thing and it's a problem. But they're like, well, technically, if you have burnout, but we look at you from like a biological standpoint and check some blood work, you're normal. Like there's nothing we can measure on you. So I feel like fatigue is kind of in that same category right now where we need better ways to measure it. So it's kind of a super long way of saying they are looking into it, and I'm really happy that they are.
Absolutely. Do you have time for a few more questions? Or
Sure, yeah.
Okay. Because we have 17 questions. I know that we're not going to be able to get through all of them. So attendees, our apologies. However, I'm going to try to get to some of the ones that are really, I think that, everybody would really want to know. One of the questions that I think we should speak to is, what is your opinion on getting sweat gland removal surgery? This person has seen a few people who have had it and are doing pretty well. Could you speak to that?
Yeah, it can work well for some people. So that's kind of that like big excision. And so one of the ideas behind it is, all right, well, if we know HS goes to these areas and that's where it tends to be, why don't we just remove the skin in that area? And hopefully that will stop the HS. Like if HS is only showing up in your armpits and we take out your armpits, it'll go away. It's a little hard to predict because like we said, there's a lot of people who have a surgery scar and the HS spots are showing up right around it. Some of the thought process is, well, if you kind of go wide enough, maybe you can get around the areas where the HS is. So it is a good option for some people. It's a little tricky because right now, most surgeons and most patients are kind of on board that, all right, when the HS gets so bad that it's taking my armpit, that's when I'm going to get rid of my armpit and kind of get rid of that skin. And that's where most surgeons are too. They don't really love to go in and kind of take out a lot of normal skin. I think if you're sort of considering that, then some of the smaller surgeries can be good options because it's almost like instead of doing it all at once, you step by step do it. Like, all right, the HS throws a left hook and you throw a right jab. So it makes a little lesion. You take that lesion out and let it heal up. If it's going to make another one, I'm going to take that one out. And you may end up in the end sort of having the whole area removed, but it's a little bit more manageable along the way. I will say it's a little bit of a challenge because, as I mentioned, some surgeons know how to do one of the surgeries and not the other. So we're really trying to train everybody and get out there so that no matter where you live, you can get all these HS treatments, because that's another huge challenge is people who live somewhere and are like, yeah, I don't have anyone I can go to who knows about this and knows how to do these things.
Absolutely. And there's a question about keeping track actually of flares. And Jillian, if you wouldn't mind, would you mind posting the link that you sent to me in the group for everyone? There's a journal that is a collaboration between Jillian and HS Connect that will help for patients to keep track of flares and diet and things of that nature and those triggers. So if she can, I think she posted it. Yeah, there we go. Oh, okay. I'm gonna have to post it. 1 second, everyone. There it is. So you can click on that link. So next question. Um, so red light therapy, are there any studies on this research?
So I haven't seen any yet on red light, but I'm going to look again because I have to think maybe someone has started. It has been shown in some other diseases to kind of calm down inflammation, like hair loss, actually. It can kind of calm down inflammation and stimulate the hair to grow. But I'm not aware of any in HS yet. So I'll look out and see if there are any for HS, but I haven't come across any yet. And that's one of the hard things about studies too, is sometimes if somebody studied something and it didn't work, then people don't get excited and they don't publish it in the literature. So then sometimes you don't know that something didn't work because it didn't work for this one or that one. But they're trying to be better about publishing stuff that even didn't work. Like, we tried this and it didn't work. We tried this and it flared it up. So I'll look for the red light, but that would be interesting to see if it could help.
Absolutely. Bianca was actually asking, besides Detroit, is there any talk about working with Northwestern in Chicago or other locations in the Midwest? I think expanding sort of the clinical knowledge and trials and things like that.
Yes. So the HS Foundation specifically is trying to kind of reach more places, and we are setting up something. So there's a National Psoriasis Foundation, and psoriasis has been doing good for a while. Like, years ago, they had lots of research and they have lots of good treatments now. So psoriasis is kind of like our friend that we're like, we're gonna be just like you, psoriasis. We are gonna get really good research and really good stuff for HS patients too. So the Psoriasis Foundation every year has a conference that they're able to get support that all dermatology residents can attend it. And the idea was, they said, all right, these are the things that we think every resident must know about psoriasis. So we're going to make sure that we get them all to this conference and teach it to them. And so the HS Foundation, we're planning the same thing. And we're kind of laying the groundwork now to have this conference where we want to bring every dermatology resident in the country to this conference and say, like, before you can graduate and be a dermatologist, these are the things you must know about HS. And we are going to tell them to you. And so we're really excited about that because it kind of levels the playing field a little when it comes to, like, oh, well, I trained in Detroit and there's these HS experts, so I'm an HS expert. Or I was at Chapel Hill, North Carolina, trained with one of the HS experts, so I know so much. And like another program where they go, oh yeah, we don't have an HS expert, so I don't really know that much about it. So we are trying to get our reach out that way. And then we're also trying to just sort of bring people in and let people know, like, hey, if you are at a dermatology program and teaching residents, we all have sort of our things that we specialize in, like this disease or that disease or this condition. And we say, like, HS is ready for you. Like, if your program does not have an HS expert, come and join us. We are a super welcoming group. So we're trying to welcome people in that way too and get an HS expert at every program. But we're also building that conference to kind of make sure all dermatologists, because I think I saw in the chat earlier, I always kind of, it's funny because I tell my non-dermatology colleagues, like, yes, if you see HS, send them to a dermatologist, because some people don't even know that that's who should be the quarterback for HS patients. And then I tell them, also just be ready, because not all dermatologists are created equal when it comes to HS. Like, dermatologists send patients to me if they're not great with HS, which is fine. Like, I'm here for them, you know? And then, oh, good. Sandra posted too in the chat. The HS Foundation has a specialty clinic finder where you can find HS experts that are closest to you. So luckily in Chicago, there are a couple good experts. It's a little trickier when you get to other areas, but we're working on that too. We're actually looking at the map and saying, like, all right, we got to reach out to some of these places where patients don't have anybody within miles and miles.
Absolutely. So I want to get to this last question. This is actually a little bit less clinical, but an anonymous attendee asked, I've been thinking about getting a tattoo to cover up my HS scars, but I fear aggravating the area could cause more HS. Do you think something like tattooing the skin can cause more flare-ups? And like, in addition to that, for someone who doesn't, like, say if you get one right here or one on your hand, like, if you have HS, do you have a propensity to get HS in that area if there's a needle piercing your skin and aggravating your skin? I think that's a better way to round that question out.
Yeah. So for the second part, does the tattoo, like, can you get a tattoo in other places? I haven't had anybody report sort of HS showing up in their tattoos. And I definitely have some HS patients who have lots and lots of tattoos and sleeves and everything. So I think it is okay to get tattoos in places where you don't have HS. I haven't heard too much about people getting tattoos on the HS scars, because that is something that's become more popular with different types of scars and even burn scars. And sometimes they even tattoo just to match your skin tone, just to kind of camouflage it a little bit. That might be something good for like patient support groups, just to see, like, has anybody done this? Is that out there? Because I haven't heard of it being a problem, but at the same time, I don't know that I've actually talked to anybody who has done it. I would say one general idea that would be good is to try to have your HS under control as much as possible before. And then another consideration maybe is the activity of the scars. Like, if they're just the scars that haven't been doing anything for a long time and the HS hasn't been active, I would think that they would be less likely to flare up even if you got the tattoo, versus if it's a scar but it still gets inflamed and swollen and drains. In that case, it might actually be better to sort of have the surgery first and have that area that's still active removed, and then think about tattoo for the surgical scar, because those tend to be less active. But again, that is just sort of me thinking about it, because I have not had anybody who actually had their HS scars tattooed to kind of hide them or cover them up. But like I said, I have lots of HS patients who are covered in tattoos, and the other tattoos seem to be okay.
Okay, that's good to know. That is really good to know. And we have several other questions, but I'm going to save these questions, and I'm going to find a way that we can actually address this outside of the summit, because I know that a lot of patients have tons of things that they want to ask, but unfortunately we can't get to everything because I need to respect Dr. Daveluy's time and then everybody else's as well. But thank you so much for providing your time, your talent, your knowledge on HS and helping us to understand exactly what this condition is, who it's affecting, and the treatments that are available. Thank you so much.
My pleasure. Thank you so much for having me. Thank you everyone for the great questions.
Also tomorrow we have the amazing, not doctor, but Jillian, who is going to be talking to us about nutrition and diet concerning HS. So please tune in tomorrow, same time, 7 p.m. Eastern Standard Time, 4 p.m. Pacific Standard Time, and we will catch you tomorrow. Thank you again to our sponsors. Thank you so much, Dr. Daveluy. We really appreciate you. And thank you so much, attendees. Bye, everybody.